So I am pleased to introduce our next presenter, Jonathon Feit. He is the co-founder and CEO of Beyond Lucid Technologies. The company provides health IT management and product development. Jonathon has an MBA from Carnegie Mellon University and also a master's degree from Boston University. And so please help us welcome Jonathon Feit.
Good afternoon. Whoa. Can you all hear me in the back? Thank you very much for having me here. And thank you so much for the introduction. My name is Jonathon Feit. I'm, as you just heard, co-founder, chief executive of Beyond Lucid Technologies. We are essentially an EPCR and pre-hospital health information exchange company. But I'm not here to talk to you today about any specific product. Rather, the reason I wanted to mention my technology background, as you heard a couple minutes ago, is that I am a technologist. And the only touch that I'm going to make on the vendor side of things, if you will, is a commentary as we go forward on the relationship that I think all of you in this room, particularly as we scope out new areas of practice and care and attention to detail of both the patient and the operational organizations behind them. The relationship, as I see it, needs to shift such that you all are in control, as opposed to the vendors being in control. And a thought comes to mind of a conversation that happened at the Community Paramedicine hearing, I suppose would be the word, in Sacramento a couple weeks ago, where a fire captain from Southern California came over to me and said that he was disheartened because he felt that technology companies in particular were taking advantage of his lack of technical knowledge and essentially trying to drive his process rather than him driving them. And so I'm going to touch on that a little bit as we go forward. So, and by the way, as you can see, the topic of my conversation here, a picture is worth 1,000 PCRs. I'm going to touch a bit on where we see technology going and how hopefully that helps your organizations on the ground. Taking a cue from the previous presenter, I'm going to try to end with some questions, and hopefully that'll stimulate some conversation both now and later. Now, I mentioned I'm not a medic. I'm not a clinician, though I am honored to work with both every day. I am a business person, I'm an MBA, and I'm a technologist, and so this gets me excited when folks start talking in phrases like EMS is a business and needs to be treated as such. How can we look into data? How can we look into operational efficiency? So I sort of feel like this kid, or possibly the googly eyes on the left, when folks start talking about the business side, the money. It's the 800,000-pound gorilla in the room that I'm going to try to talk us through as we go discussing community paramedicine and mobile integrated health today. And so I was thrilled a couple weeks ago at Pinnacle to see an old friend, shall we say, show up in a presentation. Gordon Gekko, for those of you who have not seen the movie Wall Street, is generally associated with another phrase that I won't mention today, but one that he says in the movie Wall Street that is probably apropos to this conversation is anything that's worth doing is worth doing for money. And over the last day and a half at this point, and certainly over several weeks prior, I've listened intently and tried to engage in the conversation around what community paramedicine is. We've heard wonderful examples here of cases being put forward, examples of community paramedicine. I see Lou Meyer sitting in the front today. California is about to engage in several pilots, hopefully, of what community paramedicine could be. The nut that has yet to be cracked is how does it get paid for? How does it get sponsored or subsidized? How to justify the cost of doing business? And so with that, I hope we can delve into a phrase that's been thrown around a lot, even in the last day and a half, which is system savings. what does it mean to save money in the context of community paramedicine, and how does that impact the organizations that you all run? The reason I use the word organizations, of course, is there's a lot of different types represented in this room. And I'm going to come back to this as we go through. But this conversation exists, whether you are public or private, whether you're large, small, urban, rural, affiliated with a hospital or a volunteer organization. At the end of the day, lights need to be kept on. And gasoline costs money. And people's time costs money, even if it's an opportunity cost of what else could I be doing if my profession is to take care of people, but I need to get paid. So that gets to this discussion also of accountable care and what it means to do things like post-discharge follow-up if you get paid to transport. So hopefully the phrase has been uttered that imitation is the most sincere form of flattery. If Matt Zavadsky is in the room today, hopefully he'll see and take pride in the fact that I think I've taken more notes on his presentations than I did in business school. So take that for what it is about my MBA experience. But I think he makes some incredible points. Shared system savings as opposed to shared savings, which is a federal buzzword that we can talk about if you'd like, but is a different technical beast, so to speak. Is really an essential conversation. Everybody in this room and everybody you work with knows that healthcare in the United States is on a crash course with destiny. We're spending too much money. People are not taking care of themselves. About two days ago, I believe it was Tuesday, 2 days ago, the medical director for one of the largest EMS agencies in the United States said to me something I'll never forget, quote, "Not everybody wants to take care of themselves. Not everybody wants to be helped." Now, I thought that was an interesting phrase, considering what we do here all day long and try to help people or help those who help people. What is not so much being discussed, and hopefully can be, is what it means not just to share, to have system savings, but to lose revenue, because all of you get paid to transport. We talk about this on a daily basis. EMS today in the United States is, unfortunately, paid in the taxi model. You get paid by the mile, cost adjusted based on your skill set and the acuity of the patient. So if we are avoiding payments, those payments are going to you. What does that mean? If we're going to delve into improving care and we're going to build a business around improving care and we're going to try to facilitate your ability to do that in alternate destinations or going out and being proactive and following up with your patients, but you're not going to get paid for that because you're helping to avoid that payment, how do we close that gap? At the end of the day, and this is, of course, Troy Hagan, I'm sure some of you all know very well personally and was represented as the prior organization in Ada County, yet was represented very well yesterday, we thought, published a remarkable telling quote in EMS World back in 2012 when he cited $3 billion in uncompensated care happening today. Well, actually, it's happening 2 years ago, I should say, in the United States. And now the movement is towards non-transport. That means you're going to get paid even less. There's a gap that needs to be filled. That Geico pile of money needs to be found and brought back to the table. Since I live and work in California, I know that system best. We're talking about $300 million a year, give or take, in uncompensated care happening today in California alone. That's a significant chunk of change, especially when you take it across the country. So the other side of the other question that comes to mind is what it means to have savings. Again, if savings mean money out of pocket, how does that sustain itself? And that's a conversation that's been, a buzzword again that's been mentioned several times in the last day and a half, sustainability. These are all fantastic ideas that everyone has brought to the table. How do we keep them going? How do we keep the lights on? And so it comes to mind as again, another sort of telling example of how this conversation is bubbling up, that back in early in 2014, the day before EMS Today, in fact, a summit was convened in Washington, D.C. By the Department of Health and Human Services, particularly ASPR, which oversees preparedness and response, where they talked about pre-hospital health information exchange. This was predicated on the idea that you could capture information in one place and move it someplace else, presumably from the field to a hospital, but also to a nursing home. possibly, or to a dialysis facility, or to a patient's family, because that's what accountable care is supposed to be. And at this summit, HHS and ASPR were very well represented, and ONCHIT led the conversation. ONCHIT, for those of you who aren't familiar, is the Office of the National Coordinator of Healthcare Information Technology. This is the organization in charge of electronic health records. So when folks ask about the ability to integrate with their hospital's electronic health record, these are the guys who make the rules around what that needs to do. And the one group that wasn't there was CMS. And this was a remarkable experience for a guy who lives and breathes and works in the electronic records side of the game, where I'm very familiar with these other organizations, and ended up sitting at the front of the room, not by choice, by the way, but because they turned from the back row and started doing the meeting in the back, so I ended up in the front. Anyway, the room was so quiet, you could have heard a pin drop on the carpet, and there were looks of confusion all over the place, and then Chief Sugiyama spoke up to the folks from ONCHIT and said, "Are you asking us to lose money?" It was a telling question, and then the conversation got really exciting after that. But the idea that the folks making the rules around how you all get paid weren't even there. And what does this mean when that conversation is trying to put more responsibility onto you and your scopes of practice, and you are returning the favor by coming up with amazing ideas? The question is, how do we fill the gap if the expectation, as I believe Matt said yesterday, we need to get a group effort and large enough sample sizes in order to change payment policy. It's going to take it's a mountain to move. It's a mountain range to move to change payment policy in the United States. So if that's not going to happen anytime soon, are there other steps that we can take collectively as an industry, as a set of providers and vendors to those providers, that will allow you to close the gap? So let's talk a little bit about the impact of community paramedicine. Again, building on some themes that have been mentioned in the last day and a half, there's been a lot of discussion around what these could be. And the question is, what are they now? If you are going to go out and try to pilot community paramedicine as such, what are your success metrics? I put my MBA hat on and I say, what's the mark of profitability, sustainability, success, that this is a project worth doing in terms of not only clinical outcomes, which everybody in this room would agree, if we can make those better, that's fantastic. But we have to also make sure the operations are sustainable so that the projects don't need to be funded on a grant for a short period of time and they don't have life beyond the end of that grant. Or worse, because of this word called sequestration, some of you may have heard about. My organization has been subjected to this, where the funds for the project suddenly go away. And now what do you do with it? When you've got this great idea and everyone's excited, you need to be able to keep it going. So one thing that jumps to my mind is how much information we all collect. Again, this came up at Pinnacle when the folks from First Watch, who do an amazing job with the ability to analyze information, talked about how they can analyze data if only they had it. Well, in my county in California, we have a problem with data. It's not fast. Doesn't get there fast, doesn't get collected in many cases at all. And we've seen this happen across the country, where the prospect of collecting information and making it useful is fantastic. The question is it being done? And if it's not being done, why isn't it being done? Do the tools not exist? Of course they exist. Are the tools not being used right? Maybe. Are the vendors not giving you what you need in order to be able to do the work you're asking for? Absolutely. But at the same time, do we have a plan of if we as a collection of technology companies, for example, could give you as a collection of practitioners all the information you could ever dream of, what are you looking for? And have we even established what those data points are? Do we know what we're going to measure? Do we know what the macro effects are, the public health implications? This was a remarkable phrase uttered yesterday, as it was earlier this week to me on that phone call I referred to, which is there is a disconnect between looking at individual patients' outcomes and looking at system-wide outcomes. Just because a patient is not being transported doesn't mean they're not going back to the hospital. They might be going another way. And do we have holes in the data that we need to fill? At the same time, on an individual level, in the San Francisco Bay Area, there is more money being pumped into than you guys could ever probably fathom if you're not following it, into something, thank you, called personal health records, which is this idea of people giving their own health information and constantly updating them and giving them to the hospital and everybody else needing to have them. The problem is they're notoriously inaccurate. They're so bad because, as was mentioned earlier today, someone's supposed to be taking 45 pills of XYZ, and they only took 30 of them. But they only took 30 of them because they didn't really understand that they were supposed to take all 45, and now they're sick again. But they forgot to give you all that information. So now the individual data that you have is bad. And so are we asking the questions of how do we close those gaps? Again, the impact is difficult to manage. Can we show causative relationships between making patients better, not transporting them, and making systems healthier, making systems more cost-effective? At the same time, the tools that you have, and as I look around this room and I think about the number of pilots that are being mentioned, at different scales and in different countries, one motif that I have heard, because I'm sensitive to the discussion of software, is we're trying to fit it in. We have a software product that we're trying to tweak to do what we need to do, or we're building our own. Or we're going out in one case that I think is really admirable, we're using an electronic health record system designed for doctors' offices, and we're trying to put them into ambulances because it seems like the closest thing we have. Why aren't you all getting the tools from the vendors to do exactly what you need? We all have the capabilities to do it. So what's holding back that process? And then this, of course, goes into the question of measurement. And so now, because of the disconnect between the needs and the tools being used in the field, that real-time data is not being accessed, even though it probably could be. And if it could be, it would be fantastically useful. But it's not being used. Maybe it's a training issue. Maybe it's a design interface issue. Maybe we've got to make this stuff so easy to use that you can turn on the system while sitting in the lobby of a hotel and figure out how to get from end to end on the record. Something we should aspire for. So the question came to me, what can we measure? And I've had folks, agencies come to me talking about community paramedicine from New York to Louisiana, Texas, and California, asking us to build out a community paramedicine project plan for them. And I always ask them, that's great, what do you want it to do? What are you trying to measure? If you're a private organization, are you looking at profit? If you're a city, are you looking at the community health? Then what data points do we need to capture? There's something on this list, and a whole lot more that's not on here, that applies to every organization in this room. We can measure organizational health as long as we know what we're looking for. So are we digging into that process as opposed to thinking it's something we have to do? Are we looking at it as from a nice to do for our communities to check? Well, there we go. So are you available for part-time afterwards? Right. So as I was saying, the question is, are we moving from something that's nice to do to something that we will have to do if we plan to walk down this path as an industry? Because even though there are amazing ideas happening in this room, and projects across the country, and as we've heard, around the world, are delving into what it means to provide better follow-up care, alternate site destination, to population health at the level of both the individual and the city or the county or the state or the country. Innovation doesn't mean sustainable. And one of the challenges that, again, that 800,000 pound and growing gorilla / whatever other animal you prefer in the room is, if you can't get paid for this, but you know it's something you want to do, can we help collectively and individually, discussions with all the people who aim to serve your organizations, and internally in your management teams and with your practitioners and your medical direction teams and so on, can we come up with other ways to justify getting rid of revenue associated with transport? Because if you're not going to get paid anyway, you may as well find some other way to fill that gap and justify the fact that you're taking all the time and the trouble to be here talking about how we're going to do it. So this leads to questions that I think are really interesting, and as we've posed these around the country, they've gotten some really interesting responses. Besides the question of what are fewer readmissions really worth, and I think this was very well stated by Matt Zavadsky yesterday, if there's a saving to the institution, why aren't they paying you for it? Or if they're going to pay you for it, how much should they pay you for it? At the same time, if you're not going to get paid by that institution, but you want to build a relationship with your community, this is happening in my own county, where the fire department wants to take up transport duties. And we ask them the question, what are you trying to get out of this? Are you trying to say that you have a closer relationship? Are you trying to hire more people? Are you trying to increase your tax base so that you have reserves going forward? What are your objectives? Because that's what needs to be justified. And it's a complex question, but if we can transition from just talking about good ideas to talking about how we're going to make them sustainable, we start digging into some seriously interesting measurement points that we have the tools, and there are a lot smarter people than me in this room who can delve into these details and come up with some very convincing cases. At the same time, I mentioned the relationship with technology. And one thing that has bothered me so much, and it's a conversation we always try to have with partner clients around the country, is a single phrase that rarely gets uttered. And it's, what are you trying to achieve? What do you want technology to do for you? There's not a single agency in this room or across the country in 5.5 years that has ever asked me to figure out how to land an ambulance on the moon. What we're talking about is documentation. And we're talking about connecting a mobile vehicle to a stationary facility. And we're talking about pulling out the information of that. It's not brain surgery. So why is it that some agencies wait years to have innovations that would help them now? Why is it when we talk about wall times in some California counties up to 3 hours because heads-up notification isn't going into the facility as to who's coming in? When we talk about telemedicine, why is telemedicine not being tied into the patient care record so that not only are you able to distinguish the difference between stroke and Bell's palsy, as was written about, I believe, in GEMS a couple weeks ago, but you have the patient care record's context alongside it, and you can look up their health record, and at the same time notify their family and their doctor of where they're going, so you don't have to go back and chase down their insurance information later, because that takes a lot of time. And as we dig into those things, we start pulling out return on investment that justifies you being here and talking about how you do new stuff. Even if it's not going to get you paid, it's going to lower your cost because you have less time waiting in the hospital. And you have fewer people fewer phone calls that need to be made when that information can flow on its own. So I wanted to bring in a couple specific examples of this. Again, picking on California because I'm there, but this is just a couple that jump to mind. For example, did you know that if we eliminate the use of paper records in the field, paper, not PCRs, but paper PCRs that then get retyped later once you get either to the hospital or back to base, whatever, someone's scanning it and doing optical character recognition, you can save $6.5 million a year? By the way, that's based on a 3.5-minute savings. 3.5 minutes of waste. Because that paper record, first of all, rarely gets read, rarely is readable. I've seen instances where I've actually played follow the paper in hospitals and watched these things end up on the front desk where anybody could come in and grab it, besides a walking HIPAA violation, literally, it becomes useless. And if we can go from paper to digital to fax, and instead go digital to health record, and you save all this time, there's money associated with that. There's also improved clinical care, and each of you is able to get your crews back out into the field that much faster. Another very telling one, I promised to talk about telemedicine. This one shocked me, because I've been in this business for 5.5 years now. And when I heard that we can, using a heads-up notification from the field in STEMI patients alone, that you could save time. I figured it was 10 minutes to activate the cath lab. When I looked at the literature, 34.5 minutes of time. Multiply that in places like California by the per minute cost of operating room downtime plus medics waiting alongside their patients for the right clinicians to show up, and this ends up being, on average, $22.5 million a year just for STEMI, just in California. And this is just for getting the right patient to the right place, matching up at the same time as the doc. It doesn't change clinical workflow. It doesn't change clinical anything. But it's when you dig into that 34.5 minutes, the largest portion of that is the doctor has to drive from home to get to the facility, or they have to come from the upstairs floor, and they have to know where and what bed and so on. Why can't we do that electronically? Well, we can. For us, this has come down to a mandate. I'm going to leave you with a question. But we've seen this process and evolution in terms of 3 pieces. And I think they've all been mentioned here at this conference, so I'm hopefully I'll bring them together. The first is the patient care record itself. Can we capture enough information in the field in a useful fashion that is so quick, so easy to use, and utilizes the same types of design principles that we all use every day on our Android phones and our Apple phones and so on and so forth, that are best practices for design that make the system so easy to capture information quickly that people not only will feel compelled to use it in the field, but they're going to enjoy using it in the field because they don't have to do as much later. Nobody gets into this business to do paperwork. So that's one piece. The second is, can we move that information fast enough that it becomes useful? So if I'm going to do community paramedicine and I need somebody to provide me with medical direction, tell me, do I transport this patient or do I not? And if I do, where do I take them? And if I don't, how do I justify it later when someone tries to sue me for not transporting them? And if I need someone to see what I'm seeing on the ground, can we move that information so quickly, in 30 seconds, maybe less? The discussion of emergency bands has come up today. I think it's a phenomenal future. We start talking about dedicated technology that moves information at the speed of technology, as opposed to at the speed of paperwork, and hand that information off so it's useful. And then be able to find those patients later, follow up with them, have that information be trackable from the field. I call this connected emergency incident response or emergency medical services. Other folks have called it EMS 2020. And my question to you is, why does it have to wait until 2020? Why can't we do this in 2015 and a half? Why can't we do it in 2016 and have everybody be hunky-dory with the use of technologies that we use in our pockets every day? GPS, telemedicine, sending pictures from this morning's balloon race to my family in Los Angeles. Why can't we do that? We can. And the way that we see this progress happening is to empower, as an industry, I hope we can empower all of you in this room and all of you around the country who are interested in moving the ball forward and need to know what questions to ask. I often say to people when I make a sales presentation, don't believe anything I say. Make us show you what we can do. And all of a sudden, when you start saying, can you do this, can you do that? All of a sudden, you have the power to tell us what you need to do that you know how to do best. And we're just trying to make tools to facilitate better care, better operations, better access, lower cost. With that, thank you very much. I know we're a bit tight on time. Happy to answer any questions that you have. Happy to tell. I wanted to put up the sources here, so these are all public. I'd be happy to share the deck with any of you. And look forward to speaking with you. Thank you very much.